I'm very happy to introduce the next speaker, and that's Emiliano Fabiani from Rome. And he will be talking about clonal evolution and therapy-related myeloid neoplasm. We're looking forward to that presentation.
Okay, well, first of all, I would like to thank the organizer of the Congress, Chairman, and Nana Onlus for the opportunity to discuss about the role of clonal evolution in therapy-related myeloid neoplasm. So, therapy-related myeloid neoplasm obviously are myelodysplastic syndrome and acute myeloid leukemia who arise after chemo and radiotherapeutic treatment for a primary tumor or an autoimmune disease. So today, unfortunately, the incidence of therapy-related myeloid neoplasm is increasing, but this is probably due to the prolonged survival of treated patients, and this is good. But on the other hand, compared to the novel myeloid neoplasm, their prognosis is very, very poor, with about 10% of survival at 5 years. So today, TMN could be defined as an emerging problem. So due to the limited incidence of therapy-related myeloid neoplasm, during here, several researchers have tried to identify specific risk factors involved in the pathogenesis of TMM. And today, the main risk factor, patient-specific risk factors, are the age, the kind of previous cancer and specific treatment, but also the presence of germline variants like polymorphism, but also somatic, but also germline mutation. And today, we now know that about 10 to 15% of patients who develop a second neoplasm develop this second neoplasm without any kind of therapy. And moreover, a familiar or a history of predisposition in these patients have been identified in about 5 to 10% of patients. So for this reason, during years, many researchers have tried to identify specific polymorphism able to depict the role as a risk factor in TMM progression. Mainly studied pathway was the detoxification pathway, in particular detoxification phase 1 with cytochrome enzymes, but also phase 2 with genes belonging to the glutathione S transferase like GSTA1, T1, P1, and etc. But also several polymorphisms involved in the DNA repair, in particular RAD51, XRCC3, and genes belonging to the apoptosis pathway like genes of the family BCL2. And in particular, we have identified a gene like BCL2L10. So, but unfortunately, due to the limited number of studied patients and the lack of larger cohort of patients homogeneously treated for the same primary cancer and this specific therapy, these results were not confirmed during time. And today, now know that germline mutation are involved in the pathogenesis of therapy-related myeloid neoplasm, and in particular, we have identified in past enrichment in germline mutation in genes belonging to the Fanconi anemia pathway, in particular FANCD2, A, and J, but also in genes like TP53 and CHEK2. But other than genetic variants, also somatic variants may have a role in the predisposition of therapy-related myeloid neoplasm. So in this line, one of the major discovery of the last years, in my opinion, was the identification by Jaiswal and Genovese et al. In the same number of the New England Journal of Medicine journal of an enrichment of about 1% of somatic or acquired mutation in healthy controls or patients unaffected by oncomatological malignancy. Moreover, they were also able to identify that this mutation may increase with the increase of the age of patients until to reach about 10% in patients aged over 70 years. And this mutation was mainly enriched in genes like DNA methyltransferase 3A, but also T2 and ASL1. And for this region, this gene were then acronymized as DTA genes. So, of note, the same genes identified by Genovese et al. And Gais et al. Have been also identified as mainly involved in the pathogenesis of de novo myeloid malignancies. In this slide, I would like to show you that now we know that the frequency of somatic or acquired mutation in de novo myelodysplastic syndromes and acute myeloid leukemia is very, very similar, with 90 to 95%, but the kind of specific somatic mutation is very, very different, with more frequently mutated genes in the field of myelodysplastic syndrome, genes belonging to the spliceosome machinery like SF3B1, SRSF2, U2AF1, and Zeta RSF2, but also genes involved in the epigenetic regulation, while on the other hand, more frequently mutated genes in the field of acute myeloid leukemia are obviously nucleophosmin 1 and FLT3. So, Lindsay et al. Have tried to identify specific mutation in 3 different cohorts of acute myeloid leukemia patients: de novo acute myeloid leukemia, secondary to myelodysplastic syndromes or myeloproliferative neoplasm, and therapy-related myeloid neoplasm. And they identified that the number of somatic mutation again was very similar, but the specific type of somatic mutation were different, with more frequently mutated genes in the field of secondary acute myeloid leukemia, again genes involved in the spliceosome machinery, but also epigenetic regulation and BCOR and STAG2. Of note, very, very recently, the ICC added RANKS1 to this list. Looking at the frequency of specific mutation in this gene, the gene that is more frequently mutated in the field of therapy-related myeloid neoplasm is TP53, that is mutated in about 30 to 47% of patients. So, the rule of somatic or acquired mutation in therapy-related myeloid neoplasm was for the first time explained by the group of Wong et al. In 2015, and the authors were able to identify in 7 TMM patients specific mutation in the TP53 gene, and then backtracking this mutation at the time of first diagnosis, that was Hodgkin, mainly Hodgkin and non-Hodgkin lymphoma. The authors were able to identify the same variants at a very, very low variant allele frequency, and this was the first identification that somatic or acquired mutation at low variant allele frequency may have a role in the development of a therapy-related myeloid neoplasm. So no more than 2 years after our group studying 14 patients, affected by therapy-related myeloid neoplasm, were able to identify, other than TP53, also mutation in ASXL1 that may expand after radio or chemotherapy. And in particular, using ultra-deep NGSSA, we were able to identify 2 different scenario of TMM pathogenesis, in which in the first scenario, somatic mutation characterizing the TMM clone were not present at the time of the primary cancer diagnosis and appear only after treatment. On the other hand, in the second scenario, we identified somatic mutations that were detectable not only at the time of TMM progression, but also at the time of the primary cancers, so after the treatment. And in this line, I would like to show you in this slide two different cases of the first scenario in which we identified at high variant allele frequency two mutations in the EXL1 gene, but we were unable to identify the same mutation at the time of the primary diagnosis, that in this case was non-Hodgkin lymphoma. So mutation in this case can be directly due to the use of chemotherapy. On the other hand, in this second scenario, as you can clearly see, mutation identified at high variant allele frequency in the right side of the slide for the case of ASXL1, but not for TP53 in the left side, were also identifiable at the time of the primary diagnosis, respectively non-Hodgkin lymphoma and APL. So in this case, the mutation precedes chemotherapy and may expand probably due to the specific role of chemotherapy in a kind or in a sort of Darwinian evolution of these clones. So to date, the role of CHIP is fairly accepted, and the CHIP have been identified in about 30 to 70% of patients affected by a therapy-related myeloid neoplasm at the time of the primary diagnosis. But despite several research groups have tried to identify the specific role of any somatic mutation in the pathogenesis of therapy-related myeloid neoplasm, probably due to the lack of a specific control. So in this case, a cohort of patients with the same treatment, but did not develop a therapy-related myeloid neoplasm, may have a role in the misidentification of the same specific gene mutations. So in this line, our group have tried to study a cohort of patients who developed therapy-related myeloid neoplasm after FCR treatment, fludarabine, cyclophosphamide, and rituximab for a primary diagnosis of chronic lymphocytic leukemia. And we compare our result with two different control cohorts. The first one was a larger cohort of CLL patients, 285 patients at the diagnostic time, and the second one was a smaller cohort of 5 patients who did not develop therapy-related myeloid neoplasm after 5 years with the same treatment, FCR. So, to avoid any chance of misunderstanding in the colosomatic variants that may be involved in TMM pathogenesis, variants in gene not myeloid specific, and also previously identified as recurrently mutated in the field of CLL, were eliminated by this list. So in particular, unfortunately, TP53, SF3B1, MYD88, Notch1, and CEDAR. Looking at the frequency of somatic mutation identified at the time of primary cancer, we identify a great prevalence in patients who did develop a therapy-related myeloid neoplasm, about 62%, as compared to that only 12% in patients, in diagnostic patients of CLL. So, and this is an example of 3 patients in which CHIP-related variants expanded following FCR treatment. As you can clearly see, in all cases, the somatic mutation identified at high variant allele frequency at the time of TMN were also identifiable at the time of primary cancer at very, very low variant allele frequency, or the same variant allele frequency in only few cases. But on the other hand, looking at the second control cohort, CLL patients who did not develop a therapy-related myeloid neoplasm. In this case, no chip-related variant which expanded following the FCR treatment were identified at the time of primary diagnosis. And in particular, we can see in the upper side of the slide a case of a patient with an SF3B1 mutation at the time of CLL that do not expand at after treatment. So all in all, our study may suggest the potential role of CHIP as a susceptibility factor for the development of a therapy-related myeloid neoplasm in patients affected by chronic lymphocytic leukemia treated with FCR. But given that CHIP is common in patients who are candidates to receive cytotoxic agents, this finding may be useful for the management of CLL, and in particular, in what kind of patient, in older patients that are more frequently affected by the presence of the CHIP variants. So in these patients, we can suggest the use of a screening to assess the specific treatment. So finally, I would like to show you this recent work about Sperling and collaborators, in which the authors studying a cohort of 416 TMN patients were able to identify, as expected, an enrichment in mutation in TP53 gene and PPM1D, but also mutation in gene known to be related to the clonal hematopoiesis, DTA gene, in particular T2 and DNA methyltransferase 3A. So as expected, the authors identified a correlation between the presence of complex karyotype and treatment with platinum agents, and also the presence of chromosome abnormality in 5 and 7 with the use of alkylating agents. But of note, they also identify a high frequency of TP53 mutation in patients previously affected by multiple myeloma treated with thalidomide analogs. So we now know that 5q- myelodysplastic syndrome patients are resistant to lenalidomide treatment. So for this reason, the authors try to identify the mechanism of resistance to thalidomide analogs in hematopoietic stem progenitor cells from mice, CRISPR engineered with mutation in not only TP53, but also PPM1D, DNA methyltransferase 3A and T2. And so in this line, the authors in this long-term in vitro competition were able to identify an advantage in clonal selection of hematopoietic stem progenitor cells carriers of TP53 mutation, but not carriers of other mutation identified in their cohort of study. So in conclusion, the pathogenesis of TMN has been revealed in the last year because of the availability of deep sequencing technique, which have confirmed that the presence of germline mutation in about 15–20% of TMN patients, but also an acquired somatic, an acquired susceptibility due to the presence of CHIP. So in the near future, a comprehensive understanding of the heterogeneous interaction between CHIP and the specific treatment will help advance a personalized approach to risk reduction and early intervention. And finally, it is hoped that improved genomic characterization of the patient's background will be the basis for treatment decision and individualized treatment approaches, not only at the time of primary cancer, but also at the time, not only at the time of TMN, but also at the time of primary cancer. So finally, I would like to thank in particular Professor Maria Teresa Voso, because without her, none of our study would have been feasible. And Dr. Giulia Falconi, Antonio Cristiano, and Jairo Lai, that are more than colleagues. And finally, you for your kind attention. Thank you very much.
Thank you very much for this very, very nice presentation, which is open for questions. Maybe I can start with one. If you look at SHIP-induced therapy-related neoplasm and compare it with probably not SHIP-induced, do you see a different landscape, or is an indication of different landscapes?
Sorry.
I'm asking because there also must be an age dependency, and as a pediatrician, we always see a lot of RAS mutations in the young folks. So I was wondering whether there are any data indicating that there could be differences in general in the landscape, irrespective of treatment.
Sorry, different landscape?
So the question was if there is a difference in the genetic landscape between the TMN and the de novo? Charlotte?
No, I was just wondering if you look at the secondary therapy-related myeloid neoplasm.
Yeah.
Oh,
And
yes.
it shows wonderful data, maybe SHIP-induced,
Okay.
maybe not
Yes.
SHIP-induced. Is there a difference in the other acquired somatic mutations, so in the landscape, if you compare the two mechanisms? Sorry, there was a complicated question, maybe.
No, sorry, no.
Into
No.
Italian language.
No, the question was, you nicely showed some of the therapy-related myeloplasma are based on SHIP,
Come?
and there's an expansion of a SHIP clone. And in other cases, you do not see the expansion of a SHIP clone, so you think it's a different mechanism. And my question was, if you compare the two groups, do you also see differences in the other mutations? So is the landscape different,
Yes.
whether you have SHIP-induced
Yeah.
or whether you do not have SHIP-induced? That was my question.
Okay, unfortunately, we haven't the right number of samples to test the enrichment on in specific mutation in these two group of patients. And this is my answer, but I haven't an answer to your question. Sorry.
Thank you very much. Are there any other questions?
Maybe I have a question
Yes.
for you. So you showed us the two scenarios,
Yeah.
the first and the second, or the secondary scenario. So do you think that is maybe a methodological issue, that the sensitivity
Yes.
might not be deep enough to find these
Yes.
SHIP mutations or predisposing mutations at the time when the primary tumor is there, and maybe single cell analysis might help here to
Yes.
answer? And what would be the clinical consequence?
Okay. Yes. So obviously, as the percentage of blast in MDS AML could be debatable. The same is for the definition of CHIP, for example. 2% CHIP, lower than ARCH, age-related clonal hematopoiesis. So in our sample, we try to use digital droplet PCR to identify this mutation, but obviously we can say, no, there isn't a mutation, but maybe undetectable, so under the limit of our assay. So obviously, in my mind, just at least one mutation in just one hematopoietic stem progenitor cell may expand as a Darwinian evolution under the effect of a therapy. So in this line, for me, is optional to establish a limit for this. Today, the limit should be our ability to identify this mutation. But this is only an opinion. Obviously.
I do not see more questions here in the audience.
Then I'm happy to pass on to you, Constanze, for the next talk. Thank you.
Thank you.
Thank you very much.
To you.
Emiliano.
Thank you very much.